that had a traumatic, incomplete spinal cord injury that resulted in paraplegia at the level of T4. She was also characterized to be within the Asia C category, and this means that motor function is preserved below the neurological level, and more than half the musculature below the level have muscle grade less than 3. So a little bit of background about this patient. This is a young female involved in a motor vehicle collision. She came to inpatient rehabilitation after about 2 weeks. So she had surgery for stability of her thoracic spine within that time frame. She had an independent vital level of function, and she was a working mother of 7 children. So in this case, right lower extremity hypersensitivity was the greatest barrier that caused me to have to modify my treatment sessions as well as plan of care. As far as frequency and duration in the inpatient setting, she received OT and PT 60 to 120 minutes per day, 5 to 6 days a week, 4 weeks from the date of the initial evaluation. And the plan was to decrease burden of care during functional activities for safe discharge home. So as far as the purpose for my presentation, one, it was to reflect my personal learning experience. This was the first traumatic spinal cord injury that I had the opportunity to work with, as well as offer information to others, get feedback from others, and demonstrate my clinical problem-solving process. So looking at some of the diagnostic testing, she had several fractures, T3, T4, T12 region. She had bilateral rib fractures. She had hematoma in the thoracic region. She had cord contusion at the T3, T4 region, as well as disruption of ligaments at the T3, T4 region, and also had a small pneumothorax in the apical region. Other findings include lumbar degeneration and cervical stenosis. As far as impairments on my initial evaluation, she had extreme right lower extremity allodynia to light touch. So this means stimulus that usually would not be painful was very, very painful to her. So observed during functional movement, she had decreased proprioception bilaterally. She was unable to determine where her limb was in space. The left lower extremity, formally assessed with proprioceptive awareness testing of joint position at rest, she was unable to determine the position at the first NTP joint. She also had impaired sensation bilaterally. Below the ankle on the left, she had decreased localization and decreased localization all the way through on the right lower extremity. As far as formal testing for the right lower extremity, it was really difficult due to this hypersensitivity, but in passive range of motion, she did have increased tone on the right side. And with velocity-dependent movement on the left, she had spasticity 1+ out of 4 on the modified Ashworth scale, which means there's slight increase in muscle tone with a catch followed by minimal resistance less than halfway through the motion. As far as strength, due to the tone, it's not as accurate, but on the left side, she had strength grossly 2+ to 3- out of 5, so she was unable to get full range of motion against gravity. And on the right side, the only thing that she had was 1 out of 5 at the glutes and the butt, so she had a small flicker there. And during functional movement testing, she had decreased motor control and coordination on the left lower extremity as well. So as far as limitations for her, she was max assist initially with rolling, max assist of 2 for supine to sit and for slide board transfers, and she was unsafe for standing ambulation or stairs initially. Her abilities included edge of bed sitting. She was able to sit at edge of bed with upper extremity support with minimal assistance. For participation, her ability, she did participate in some social activities, including spinal cord education group. This helped her understand more about what to expect with spinal cord injuries, as well as participation in therapeutic recreation, so socialization outside of her therapy sessions, including ceramics and painting. And she also engaged in phone conversations with family and friends outside of therapy sessions. As far as restrictions, she was restricted as a mother, wife, coworker, friend. She was unable to drive or perform any of her household activities that she's used to doing. So for environmental factors, positive environmental factors, she was very motivated, pleasant, engaging, goal-oriented. She had a positive attitude. She had a good support system outside, including a significant other, and then his mother that helped with all of her children. and as well as a brother that helped out a lot. As far as negative environmental factors, she had a negative self-image of herself. She didn't really want to see, wanted anyone to see her the way she was. She had to wear an aspen collar at all times. Her CTLSO had to be donned when the head of the bed was greater than 30 degrees or went out of bed. She had no insurance initially. As far as home environment, she had stairs to enter the home, so she had 2 and then an additional 1 to get in, as well as a full flight of stairs to get up to her main floor where the bedroom was. As far as goals, each patient that came through got a binder that we could put information on HEP, educational information, discharge information, and there was also a goal section where they could be involved in their goal setting. So this allowed us to have more patient-centered goal setting. So for week 1, I shot for mod assist with sideboard transfers and bed mobility, max assist with supine to sit transfers, edge of bed sitting with supervision, toleration of wheelchair propulsion, improving sensitivity of the right lower extremity by 50%. So this is definitely something that I would like to research more on, would be the finding an objective measure for the sensitivity, because I pretty much got like a verbal description of sensitivity. So maybe looking into a more objective measure for that. Other goals include verbalizing, her being able to verbalize her precautions and participate in that spinal cord education group. For long-term goals for up to 4 weeks, I shot for supervision with sideboard transfers, modified independence with wheelchair propulsion up to 100 feet, mod out with bed mobility, increasing her right lower extremity strength glute and quads to 2 out of 5 and left lower extremity strength to 3+ to -4 out of 5. And with these goals, it's kind of hard to make because you don't really know what kind of neural input they'll get to the other musculature. So I had to make my goals based on what I already knew that she had. And then to be able to tolerate a walking assessment. So for week 1 equipment, this is similar to the aspen collar that she had to wear at all times. The CTLSO beside it looked very similar to what she wore. A step stool, whenever we got to edge of bed, when her right lower extremity was dependent, it was extremely painful, and she did not like her foot to be on the floor, so I kept this step stool in her room. So every time I got to edge of bed, the foot was placed directly on the stool. And then also pictured is a slide board and push blocks to assist with transfers. The picture of the wheelchair, that's the wheelchair she used throughout her stay. The leg loop helped her become a little bit more independent with the transfers and to help self-manage some of her pain that she was having, as well as the Prevlon boot when she was laying in bed so that I could prevent pressure sores due to the decreased mobility that she had. So looking at a summary kind of week 1 interventions, week 1 consisted mainly of getting out of bed, increasing time in the wheelchair, as well as decreasing that sensitivity of the right lower extremity. So some of the desensitization techniques that I used, light touch tapping, progressing to light pressure from the hip all the way down to the foot. And she was also able to do this within her room to the constraints of her precautions as well as the constraints of the brace. But she could only do it to about mid-thigh or so. But when she had family, when she had her significant other, he kind of assisted with that as well. Right lower extremity passive range of motion stretching to maintain joint integrity. Right lower extremity active system range of motion with motor imagery. So what I did with this, she did have that slight 1 out of 5 activation of the glute and quads. So I got her to think about the movements as I assisted her with it. And then for left lower extremity, we did some strengthening, glute sets, quad sets, ankle dorsiflexion, plantar flexion, straight leg raise with assistance. Worked on the functional activities like spinal transfers, so improving technique. Every patient's going to have a different technique that works best for them. Decreasing the assistance that's needed. Worked on some anterior trunk flings to help prepare for transfers, as well as introduction of that lower extremity strap to help improve independence. As far as rolling, we worked on the log rolling technique and to increase independence with that for improving donning of CTLSO, clothing, use of bedpan, and continent episodes. Another intervention important for week 1 was education. So reviewing the precautions, she did have cervical and thoracic precautions. Education on autonomic dysreflexia, which can be an emergent situation in patient and spinal cord injuries with injury T6 or above, as well as spinal cord anatomy, reviewing the wheelchair parts, reviewing sequencing of the task, and pressure relief techniques as she increased time in the wheelchair. As far as week 1 progress, she met all of her goals in week 1. She was mid-assist with sideboard transfers, mod-assist with bed mobility, with the head of the bed elevated for that supine to sit. Edge of bed sitting, she was supervision. She could propel her wheelchair with supervision 200 feet. And her sensitivity improved from a stabbing pain to a tingling pain. And she was also able to verbalize her precautions and participate in the spinal cord education group. So week 2, over the weekend after week 1, she did have a turning schedule in her bed for pressure relief, but the nursing didn't get her out of bed. And so when we came back on Monday, she had a new complaint of right knee pain, severe right knee pain. And so given her history of traumatic event, I did discuss with the physician. She did get an x-ray and it was unremarkable findings, negative ligament testing. But she did have some emergent tone in week 2. So I think that was a contributing factor as well. So with that, I did some gentle passive range of motion stretching, gentle distraction of oscillations of that joint, some muscle relaxation. She began to have more muscle spasms, so gentle rocking and oscillations of the tissue. And also weight bearing. So week 2, I began more standing activities. So the tilt table shown above here began 0 to 60 degrees. So just initiating some of the weight bearing, and also to monitor cardiovascular regulation. After a spinal cord injury, there can be some changes there. And she did have some fluctuations on day 1. But on day 2, she was able to stand in the tilt table for up to 20 minutes with good vital signs, and we were able to do some postural control stuff like throwing the beach ball back and forth. As well as we did some exercises with the right lower extremity. So we did some side lying on the powder board, which is pictured there. And I did some facilitation tapping of the musculature to help facilitate muscle activation there. So other interventions, joint approximation to help get neural input into the knee and ankle, bilateral lower extremity weight bearing with glute lifts from the mat to help with initiating sit-to-stand and transfers, transferring from wheelchair to mat to both sides because she was having extreme pain going to the right, but you're not always going to be able to transfer to one side at all times. And then transferring from different heights because you're not always going to have a mat that stays at the same level. And then improving rolling techniques. So other techniques that I introduced were gentle serratus punch with momentum to kind of help facilitate that. And continuing education on pressure relief every 30 minutes while up in the chair, and practice taking on and off wheelchair accessories so that she become more independent with that. As far as benefits for standing adults following spinal cord injury, following risk assessment to determine if they're appropriate for standing, it can decrease muscle tone and increase range of motion to functional limits for previous activities. It can reduce bone demineralization. It can improve postural control, strengthen anti-gravity muscles, and help with balance reactions. As far as week 2 progress, by week 2, she was able to perform sideboard transfers with contact guard assist. She needed minimal assistance with head of bed elevated to find the sit transfers, and she still had difficulty with rolling due to assistance still needed with that right lower extremity due to the sensitivity. So for week 3 equipment, she had an SUV, so she would be discharged using an SUV. So we had to do some car transfers. We had a car simulator that was able to, you were able to change the height to simulate the vehicle that you'd be transferring from. So she was able to do that with the use of a slide board and a step stool with minimal assistance. So she did really well right off the bat with the car transfer. I also initiated standing within the parallel bars. After mod assist and min assist of 1 to stand, she was able to maintain it within the parallel bars for 10 seconds with supervision. Some other interventions for week 3, trying to continue with techniques for the supine to sit. That seemed to be the struggling point as far as transfers. So different techniques we use, walking up and down with the elbows and forearms, ball rolling to one side and pushing up. Both seemed to, she still needed about the same assistance. One didn't really work better than the other. So just kind of continue to work on that. And desensitization. I did passive range of motion at different speeds. She was able to tolerate a little bit more with handling at the right lower extremity. Progression of strengthening of the left lower extremity with ankle weights, as well as continuation of right lower extremity gravity eliminated on the powder board. So by week 3, she had a 2- out of 5, and all the musculature on the right lower extremity except for the dorsiflexor, she had a 1 out of 5 there. So that was exciting to see some of the other neural input getting to some of the other muscles. Wheelchair negotiation of obstacles and on resistive surfaces, practice that. So in the instance she had to negotiate something within her home, and dynamic sitting balance on foam and with bilateral upper extremities. So within week 3, you start discharge planning on day 1, but by week 3, it's time to start getting together all of the equipment that she may need going home. So she was going to be going home in a wheelchair. So one of our therapists does all the wheelchair evaluations. And I was able to sit in and give my input versus what I thought she would be appropriate for with some of these things. She did qualify for a K5 chair, which is lighter. You can change the position of the wheels so for the best optimal positioning of the arms, as well as she would be doing most of her ADLs in the chair for a longer period of time. So other items that were included, armrests that were adjustable, so she needed to get up under a table, pull the lock, wheel lock, so when she's propelling, she's not getting her hands stuck on the locks. An Invacare Matrix Elite backrest, so this had a slight contouring on the side to help with trunk support. So once she gets her brace off, she's going to need a little bit more support due to not having the support of the brace. We did recommend a use of a lower backrest in the instance so that it would be a little bit more easier for her to get the range of motion in her arms. A Rojo Hybrid Elite cushion, seat cushion, like pictured in the picture there. The front is made of foam to help with ease of transfer, and the air cells in the back help with pressure relief. Rear anti-tippers for safety, push handles for the caregiver to assist, and spoke wheels to help with decreasing the weight of the wheelchair. As far as week 3 progress, she was supervision without the use of a slide board by week 3. She was min-assist with rolling. She was still mod-assist for supine to sit. She was able to do the standing assessment as well as the car transfer. So week 4 consisted of a family conference to get the family prepared for what's to be expected for discharge. As far as caregiver training, including bumping up and down 1 step. So she did get a ramp put in at her home, but she did have 1 more step to enter her home. So teaching the caregiver how to bump up and down the 1 step, teaching assistance needed during transfers, going through the HEP, so giving some exercises and stretches to help maintain what was gained in therapy, as well as reviewing the car transfer and donning and doffing, being able to don and doff those braces. Week 4 also consisted of pre-gait activities, so stepping forward and back and weight shifting. And as you can see in the picture, this is similar to how I wrapped my patient's limb. I wrapped the knee to help with stability and proprioceptive awareness of the knee. And then I also dorsiflex assisted the right ankle due to the dorsiflexion decreased activation. And we continued to work on supine to sit since that was a transfer that was difficult for her. And we also initiated walking with a platform walker. So this is a picture in the center similar to the platform walker that we used. I also had a mirror in front of her for visual feedback. She wasn't able to look down at her feet due to the constraints of the brace, as well as her precautions. As far as the TED hose and the abdominal binder shown in the center, this was to help keep her blood pressure from dropping during standing and walking activities. And then the ACE bandage is there. And then the picture of the wheelchair, that's the loaner chair that she got until to go home in until her specialized chair came in. and she was able to ambulate 17 feet with the platform walker. And as far as tactile cueing and where I stood for assistance, I stood behind her and helped with weight shifting at the pelvis. She actually had fairly good quad control during stance phase, except for the exception of hyperextension of the knee. So I stood behind and blocked the knee from hyperextending during stance phase. And then I had another assistant beside assisting with direction of the platform walker, as well as for safety in case the knee were to buckle. As far as gait rehabilitation strategies for spinal cord injury, gait training with assistive devices are more beneficial when applied sooner than later after onset of injury and motor incomplete lesions. This systematic review showed several studies on body-weighted support treadmill training versus conventional, and there was no true definition for conventional. It was assumed to mean overground rib training or within the parallel bars. There was 2 randomized control trials that said there was really no difference within a 12-week period between the 2. Then there was a non-randomized control trial that did show a difference and said that the body weight supported treadmill training did show more changes in locomotion versus the conventional. And with this, I would have liked to have tried the body weight supported treadmill training, but due to her she always felt really uncomfortable in the brace, felt like it was really, I had to adjust it several times throughout the sessions. And then the sensitivity with the harness, the way the harness was, it would have been really uncomfortable for her, so it wasn't really appropriate. So I had to stick with the conventional approach with that. And then the article also mentioned functional electrical stimulation as being, with gait, being an overall positive adjunct and enhancement to gait training. And I would have loved to have tried that too, but due to her sensitivity on that side, it wasn't really deemed appropriate. And as far as week 4 progress, she was still mod assist from a flat surface. She's still in supervision with the head of bed elevated. So with the hospital bed, she was supervision. She was min assist with rolling still. She needed supervision with transfers. She wasn't able to see where she was at. And with the uneven transfer, she still needed supervision. And she was able to do the wheelchair propulsion on some uneven surfaces with minimal assistance, and was able to perform the walking assessment. As far as discharge, I recommended home health PT so that they could assess the safetiness within our home. I gave the significant other resources for dimensions of the step stool for the car transfer, as well as the dimensions of a ramp. She went home with a slide board, also a hospital bed. Since she did still need mod assist from a flat surface, she would be able to have the head of bed elevated and be more independent with that. The leg loop to help with being more independent with the transfer, CTLSO, Aspen collar, and she did go home with that wheelchair loaner chair because a custom wheelchair process can take up to 3 months going through the insurance and all the processes. As far as outcome measures, I looked at the functional independence measure. This is the 18-item scale that looks at motor and cognitive areas. The scores can be between 7, which is complete independence, or 1, which is complete total dependence. Initially, at initial eval, with transfer, she needed 2 people, so she was considered dependent. And then locomotion with wheelchair and walking did not occur. At discharge, she did still need mod assistance from a flat surface, but like I said, with the hospital bed, she was supervision. And then locomotion with wheelchair, she was modified independent, and then walking, she still needed 2 people, so she only still had a score of 1. And with the FIM score, there's no MCID for spinal cord injury, and it can be variable depending on the spinal cord injury. There was some norms for thoracic and HSC, but I didn't see any that were specific to each of the mobility tasks here. Another outcome measure I used, care tool discharge performance. This Medicare is trying to come up with a different payment system to collect data that they're trying to standardize some of the acute and post-acute settings. So this is another outcome measure that I used. Things I would have done differently, I would have researched more on outcome measures. The APTA has a few good resources there as far as spinal cord injuries that you can look more into, and I will too. Research more on desensitization techniques. Monitor the exact time when the physician changed medication to determine if my interventions were effective or not. So with the changing in tone and the neuropathic pain, he they did adjust the medication. So maybe seeing the exact timing to see if my interventions were effective, and provide more education to nursing early on, so that maybe we can prevent some of the effects of that happened on the first week. And these are my references. Any questions?
We'll let other people go first.
I have one question. Just when you talked about face wrapping the knee, can you describe that a little? To just wrap around it, just to give her something else around it?
Yeah, I still did the figure 8, so it wasn't completely wrapped. But I used it for proprioceptive awareness of the knee, as well as to support for some stability. I did during stance phase.
And then did the dorsiflexion ace wrap in addition to, or?
Yes, in addition to,
Okay.
because I found that with the other technique where you're bringing it more up the lower leg, it kept sliding. So this is a different technique that I use, and it seemed to work just fine.
Sorry, kind of spinning off that, did she go home with Ted hose, or did she do any type of other treatment?
No, she just went home with what was provided. And
Okay. Okay, so I think I have a pretty good idea, but can you tell us why she was having so much difficulty with the bed mobility and coming to sit?
Well, the brace for one is a hindering factor. It's an additional weight there. It makes it difficult because you have that additional weight and you have the constraints of the cautions. So we tried both techniques. And she had an increased BMI as well. So it was quite difficult for her to initially to be able to lift her trunk to the sitting position. So we tried walking up and down with her elbows and forearms, and log rolling and pushing up, and both seemed to be more so about the same assistance needed to do it.
Yeah, those TLSOs really
Yeah.
provide a lot of stuff. How long would she got like about 8 or 12 weeks? How long was she going to be in that?
I'm not exactly sure exactly the time frame that I think she had to go back to the physician. I guess that he would let her know on the extended time that she would be in it.
So she went home with it. So how's she going to get out of bed?
So she went home with assistance. She had her brother assisting during the day and her husband in the evening to help assist.
No equipment, no overhead frame or anything, or
No.
bed loops or anything. No.
She had the hospital bed that she went home with. So
she
with that,
was
she was
bringing it up.
supervision.
Okay.
Yeah.
Why a platform walker?
Well, like I said, I would have loved to did the body weight supported treadmill training, but due to having the harness, it would have made it really hard to, it made it really painful probably for her and uncomfortable. So the platform walker was kind of what we went to first, as far as the support of the upper extremity. She had really good upper extremity strength. So
why a platform? Did I miss something? Did she have distal injuries? Like why the platform versus a
Just
walker?
due to the just the trunk stability, and so that I could focus more on the lower extremities, just to have more support of the trunk, so that I could focus more on the lower extremities. Because she was max assist during max assist of one and then assist of another for ambulation.
And then with her, I didn't see anything about wraps early on when you started doing the tilt table and all that. You mentioned wraps later in week 4. Were you doing wraps and abdominal binders when she's on the
Yes,
tilt
she
table?
had the abdominal binder every time before. When she donned that CTLSO, she had the abdominal binder on as well as the tetros.
I had more of it when people go, oh, why the FIM instead of the skim?
That was the standardized test that they used, and I actually looked into that more when I was doing research in the spinal cord injury edge on the ACTA website. They did mention that that was a standardized test that they used in the inpatient facility I was at. So.
And one more. How did you get her approved for a K5 wheelchair when she had no insurance? Did she have other?
Oh, I'm sorry, I didn't mention that. She actually got approved by Medicaid by the end of our stay. By the end of her stay. Yes, it was really fast.
Come through that quick. So did you have to write a letter of medical necessity for that?
I didn't per se, but I still went through and kind of did it myself to kind of see what I would write. But the therapist that did all the wheelchair evaluations, she's ultimately the one that did it.
Maybe one more question. Sorry, I was paying attention. You said you did not use FES because you thought it would be inappropriate because she was hypersensitive?
Yes.
Did you try it, or you just
I didn't.
assumed that she would
I
not?
didn't because the hypersensitivity and the knee pain that she was having, and we didn't really have, by the end when she started getting less hypersensitive, it was kind of getting to the point where I at least wanted to get some good weight bearing both lower extremities, so I didn't attempt the.
Don't shy away from it. It may have actually helped.
Yeah.
It, depending on the parameters. But.
And she did have some fluctuations in blood pressure as we began to do that on the last week, so it was just short bouts of ambulation. But yeah, that would have been. Even with the, as far as functional E-stem, with the hypersensitivity, do you think that would have been appropriate to do even with the hypersensitivity?
There's no saying that it's going to make it work. I mean, it's something to try. Like, if she doesn't tolerate it, then you stop it. But it could have actually even helped with the hypersensitivity.
Was she sensitive enough that she wouldn't have even tolerated electrodes on?
Well, initially she was, and she got to the point where, like, even with passive range of, once she got the knee pain, that was like an added factor on top of the hypersensitivity. So it was just a matter of comfort. Like, I didn't want to exacerbate any of the symptoms. I didn't want her to get discouraged from walking more because of the increased pain. So.
And did the knee pain dissipate? I mean, did you ever find any cause of it, or was it just something that suddenly came on?
It just suddenly came on. Like I said, there was a lot of emergent tone that happened in that second week when the knee pain came along. So I'm thinking maybe that had something to do with it. But it kind of dissipated towards the end a little bit. I mean, it was still there, but it wasn't as pronounced.
You have fun?
I did. I really enjoyed patient